If you run a surgical practice, orthopedics, cardiology, spine, anything with high dollar procedures, prior authorization is probably the single biggest bottleneck in your operation. And right now, there's a whole wave of AI vendors telling you that they can solve this. And I'm going to tell you why most of them cannot and what we've actually found works. I'm Chanie Gluck, and let's talk about the surgical prior authorization bottleneck. So here's the reality of the surgical prior auth today. Almost every high value dollar procedure your provider wants to perform needs approval from the insurance company before you can do the procedure. And that's been true for many years. What's changed is the volume and the complexity. Payers have tightened their criteria. The clinical documentation requirements have gotten even more specific, and the peer to peer reviews are more aggressive. And the turnaround windows have, if anything, gotten shorter. And here's the part nobody likes to say out loud. The payers have an incentive to make this process hard. Every day a procedure is delayed is a day they don't pay for it. Every prior auth that gets denied on the first pass is one your team has to spend hours appealing. So your clinical staff is now spending a meaningful chunk of their week wrestling with prior auth paperwork instead of seeing patients or dealing with the patient experience. Your front office is fielding calls from frustrated patients whose procedures keep getting pushed back, and your revenue cycle team is watching things slip from this month to next quarter because surgeries that should have happened in March are happening in May. And that's the bottleneck, and it's getting worse every year. And why does this matter on the financial level? Two reasons. The first is direct revenue timing. A surgical procedure that gets delayed by weeks doesn't usually get canceled, but it does get pushed into a later collection cycle. Multiply that across the year of procedures, and you're looking at a significant cash flow swings for mid-sized surgical practices. The second reason is denial risk. When a prior auth is rushed, when your clinical team is putting it together at the last minute because the surgery is scheduled in a couple of days, the documentation is weaker. Weaker documentation means a higher chance that the procedure will get denied, even if the same auth came through. Or it means the appeal process gets dragged out for months. And there's a third cost, which is harder to measure, but a very real staff burnout. People doing prior auths at most practices are not the people who signed up to do prior auths. They're nurses, surgical coordinators, administrative leads, and they're spending their best hours on payer paperwork, and they burn out and they leave, and you're left training somebody new on a process that takes a year to really master. So when we talk about prior auth bottlenecks, the cost isn't just the delayed surgery, it's the cash flow, the denial risk, and the people you're losing because of it. So let me tell you what does not work and what does. What doesn't work is the wave of pure AI prior auth tools being pitched right now. The pitch sounds great. Feed the clinical note into AI, AI writes the pre-auth packet, you submit it, and done. The reality is different. The surgical prior auth requires clinical judgment. AI can pull words from a chart, but it doesn't know which payer's medical necessity criteria tightened this quarter. And it doesn't know that a particular plan needs a specific peer review citation for a spinal fusion approval. It doesn't know that the cardiologist note from last month is the missing piece of the justification the payer is going to ask about. Bet your prior auth operations on that, and you'll see your first pass approval rate drop and your appeal volume climb. What does work is specific architecture, and the principles are the same whether you built it in-house or contract out for it. And there's three pieces. First, the work needs to be done by people who do nothing else. Surgical pre-auth is a specialty in and of itself. The criteria change, the payer behavior shifts, the documentation expectations are rarely written down anywhere. A clinical staff member splitting their time between patients and pre-auth packets cannot reasonably stay current. Dedicated capacity, even if it's just one or two people in a mid-sized practice, outperforms scattered effort almost every time. Second, the work has to run ahead of the surgical calendar, not in response to it. The single biggest correlation of pre-auth pain is starting the packet when the procedure is already on next week's schedule. Strong operations work the queue 2 to 4 weeks out, which leaves time for additional documentation requests, peer-to-peer scheduling, and appeal preparation without compressing the patient's care plan. Third, every submission should be built like it might be appealed. Specific clinical citations, payer-specific medical necessity language, documentation of trials of conservative care where required, and a clear evidentiary chain, a packet that wins on first submission and a packet that would have survived an appeal. And the inverse is also true. Rush packets that scrape through on the first pass often fail on the second when the payer pushes back on a borderline approval. AI absolutely has a role inside this architecture. Surfacing prior auth denials by the same payer for the same procedure, flagging missing documentation elements, generating draft language for specialists to review. As a co-pilot is useful. As the pilot, it's exposed. The clinical and payer-specific judgments has to come from a credentialed human who has seen this payer reject this kind of submission before and knows what gets it across the line. Let me describe how this pattern unfolds in a typical surgical practice. A surgical group, say orthopedic or spine, has a steady volume of high-dollar procedures coming through the calendar. The clinical team identifies a procedure that needs pre-auth, the packet gets pulled together, it gets submitted, and everyone waits. Days go by, the payer comes back asking for additional clinical documentation. The clinical team scrambles, the packet gets resubmitted, and more days go by. The peer-to-peer review gets scheduled, but the slot is weeks out. By the time the approval comes through, the patient has been waiting almost a month. The surgeon's frustrated because the calendar isn't filling. The scheduler is fielding calls from patients asking why the procedure keeps getting pushed out. And the bottleneck didn't start because the procedure wasn't justified. It almost always is justified. It started because the pre-auth process is built for the payer's pace and not the practice's. And when documentation gets rushed, the appeals on the back end get worse, which only compounds the problem on the next cycle. Practices that get out of this trap aren't relying on a magic AI tool. They put specialist eyes on the pre-auth queue. They work it ahead of the calendar instead of in response to it. And they build packets through thorough enough that the appeals don't come back. The mechanics aren't glamorous, they're just work. If your surgical pre-auth is dragging, if your surgeons are frustrated, your schedulers are exhausted, and your calendar isn't filling out the way it should, the answer probably isn't a faster AI tool. The answer is almost always three principles I just walked through: dedicated specialist capacity, working the queue ahead of the calendar, and building submissions that would survive an appeal. Whether you bring that capacity in-house or contract out for it or rebuild the workflow you already have, that's the architecture that moves the numbers. If you want a single diagnostic for whether your operation has this problem, look at your first pass approval rate by payer, broken down by procedure category. If any single payer is materially below the rest, that's your starting point. Fix the documentation and submission pattern for that payer first, and the rest usually follow. I'm Chanie Gluck, founder of 4D Global. Don't let the payer's paperwork run your surgical calendar.